All right, welcome back. Today we're diving into something that starts out kind of sneaky, just a bit of extra fluid, but can turn into a full-blown medical emergency in a flash. We're talking about pericardial effusion and its dangerous cousin, cardiac tamponade. So let's break down exactly how this all goes down. So let's start with a really simple picture in our heads. Think of your heart, right? It's this amazing pump, beating away, and it's sitting inside this thin, tough little bag. Now, what happens if that bag starts to fill up with fluid? I mean, really starts to fill up. What's going to happen to the pump that's trapped inside? That one question, that's the whole game right there. Okay, so let's put some official names to what we're talking about. When that bag just has some extra fluid in it, we call that a pericardial effusion. It's an abnormal collection of fluid, for sure. But when that fluid keeps building and the pressure gets so high that it actually starts to squeeze the heart, so much so that the heart can't even fill up with blood properly, well, that's when we've crossed into a really dangerous situation. That is cardiac tamponade. And trust me, that's a life or death emergency. So here's how we're going to tackle this. We'll start with the basics, the heart and its sac. Then we'll get into why this happens and what the consequences are. After that, we'll talk about reading the clinical signs, the tools we use to diagnose it, and finally, the really important part, how we relieve that pressure. All right, first things first, let's talk about that sac. What exactly is the pericardium? You know, the pericardial sac is pretty brilliant. It's not empty. It normally has a little bit of fluid in there, maybe 10 to 50 milliliters. That's just a few tablespoons. And its whole job is to be a lubricant, so the heart can beat and beat and beat without any friction. It's perfect. The problem, of course, is when you get too much fluid. And that fluid can be different things, right? It could be a thin, watery fluid called a transudate, or a thicker, protein-filled one called an exudate, which usually points to inflammation. Or it could be something more serious, like pus from an infection, or even straight-up blood. So that's the what. Now for the why. Why on earth does this fluid start building up? And what are the real consequences when it does? And wow, when you look at the list of causes, it's a lot. The list of suspects is huge. You've got infections, things like viruses or even tuberculosis. You've got cancers, especially lung and breast cancer, that can spread there. Then there's the whole category of autoimmune diseases like lupus or rheumatoid arthritis, where the body's own immune system causes inflammation. And it doesn't stop there. Metabolic issues like kidney failure, direct injury after a heart attack or surgery, even trauma. It really can be caused by almost anything. So how does it spiral out of control? How do we go from just some fluid to a catastrophic failure? It really is like a set of dominoes tipping over. First, the fluid builds up. Simple enough. But as it builds, the pressure inside that sac just skyrockets. Step 3, that pressure starts to literally squeeze the heart chambers shut. The ventricles, which are supposed to relax and fill with blood, just can't. They're being crushed. And well, if the ventricles can't fill, they can't pump. That means the amount of blood getting out to the rest of your body, your cardiac output, just plummets. And that, my friends, is the definition of shock. But here is a super, super important point. It's not just about how much fluid there is. It's about how fast it got there. Think about it. If the fluid builds up slowly, over weeks, what we call a medical tamponade, that pericardial sac actually has time to stretch. You could have a liter, maybe even more in there before things get critical. But if it happens fast, like from a chest injury, a surgical tamponade, the sac has no time to stretch. It's rigid. In that case, as little as 200 milliliters of fluid, that's less than a can of Coke, can be absolutely fatal. So it's not just volume, it's velocity. Speed is everything here. Okay, so we know the how and the why. Now let's get practical. Let's go to the bedside. What does this actually look like in a patient? What are the signs we need to be looking for to catch this emergency? You know, the tricky thing is, a lot of the symptoms are pretty vague, especially at first. The person might just feel short of breath, or dizzy, or just weak. The body's smart, though. It tries to compensate. The heart's not pumping enough blood, so what does it do? It starts beating faster. That's your tachycardia. The body isn't getting enough oxygen, so you start breathing faster. That's tachypnea. But eventually, the compensation fails. As that cardiac output keeps dropping, the blood pressure follows it right down. And that's when things get really serious. Now, for tamponade itself, there's this classic trio of signs that every medical student learns. It's called Beck's triad. It's 3 things. 1, hypotension, low blood pressure. Makes sense, right? The pump isn't working. 2,
distended jugular veins. You'll see the veins in the neck bulging. Why? Because blood is literally backing up in traffic, trying to get into a heart that's being squeezed shut. And 3, muffled heart sounds. When you put a stethoscope on the chest, the heartbeat sounds really quiet, really far away. And again, that makes perfect sense. You're trying to listen through a bag of fluid.
Okay, here's a really cool but also really important physical sign. Let me ask you this. How could something as simple as taking a breath actually change the blood pressure in someone with tamponade?
It's a wild phenomenon called pulsus paradoxus. See, normally, when you take a breath in, your blood pressure drops just a tiny, tiny bit. No big deal. But in a patient with tamponade, that drop is huge. We're talking more than 10 points. And the reason why is just fascinating. When you breathe in, more blood rushes back to the right side of your heart. In a normal heart, no problem. But in a heart that's already being squeezed from the outside, that extra blood makes the right ventricle swell. And because there's nowhere else to go, it bulges sideways right into the left ventricle. It basically crushes the left ventricle from the inside so it can't fill properly and pumps out even less blood. It's a brilliant and dangerous piece of physiology.
And check this out. You can literally see it on an arterial line tracing. Look at the waveform here. See how the peaks, which represent the systolic blood pressure, are pretty high? Now watch what happens during inspiration. See that huge dip? That's it. That's pulsus paradoxus, plain as day. It is one of the most powerful clues you can find at the bedside.
So, the physical exam makes us highly suspicious. But to really know what's going on, we need to see inside. Let's open up the diagnostic toolkit.
And really, when it comes to diagnosis, there is one test to rule them all. The echocardiogram, an ultrasound of the heart. It is the absolute gold standard. I mean, look at this image. You see the heart beating there in the middle, and all that black, empty-looking space surrounding it? That's fluid. That's the effusion. You can't miss it. It's definitive. But what's so powerful about the echo is that it doesn't just show us the fluid. It shows us what the fluid is doing to the heart. We can see the signs of high pressure in real time. We're looking for things like the right atrium, the chamber with the lowest pressure, literally collapsing at the end of diastole. Or we'll see the right ventricle, which should be expanding, actually caving in. These are direct visual proof that the pressure outside the heart is higher than the pressure inside. We'll also see that the big vein bringing blood back to the heart, the IVC, is wide open and not collapsing when the patient breathes. It's just another sign of that massive traffic jam we talked about. And just to put it in perspective, let's compare. On the left, you have that beautiful, clear, dynamic echo. You see everything. On the right, that's a chest x-ray. Now, with a really big effusion, you might get this classic water bottle heart sign where the whole cardiac silhouette looks like a giant flask. It's a clue, for sure, but it's so nonspecific. It doesn't tell you anything about what's happening to the heart chambers inside. It's just not in the same league as the echo. Of course, there are other helpful clues. On an ECG, you might see low voltage across the board. Again, this makes sense. The fluid is acting like an insulator, dampening the heart's electrical signals. And sometimes you see this really wild textbook finding called electrical alternance. The QRS complexes on the ECG literally get bigger, then smaller, then bigger, then smaller. That's because the entire heart is physically swinging back and forth in that big bag of fluid with each beat. And of course, blood tests can help us hunt for the underlying cause, like signs of inflammation. Okay, we found the problem. We've confirmed it's life-threatening. Now for the million-dollar question. What do we do about it? Really, the entire management strategy hinges on one single question. Is the patient stable or unstable? Are they in shock? If the answer is yes, if they have tamponade physiology, then there is no time to waste. The treatment is an immediate, life-saving procedure called a pericardiocentesis. You get a needle in there and you drain that fluid, period. Now, if the patient is stable and it's just an effusion without tamponade, we have more time. We can focus on figuring out the underlying cause and just keep a close eye on them with serial echoes. Now, it goes without saying, putting a needle that close to the heart is a big deal. It's not something you do lightly. There are risks, for sure. You could potentially puncture the heart muscle, hit a lung, or cause a dangerous heart rhythm. But, and this is the key thing, when a patient is in tamponade, the risk of doing nothing is basically 100% mortality. So in that context, the risk of the procedure is absolutely worth it. And this really brings us full circle, because once you've drained that fluid, once you've relieved the pressure and saved the patient's life, the job isn't over. In fact, in many ways, it's just beginning, because now you have to answer the most important question of all. Why did this happen? That fluid gets sent off for analysis, and the real detective work starts, trying to find the root cause. Because fixing the plumbing is one thing, but figuring out why it broke in the first place, that's the real key to helping the patient long-term.